without further ado, I'll go ahead and introduce Chris from Pedifix. Pedifix is one of our special sponsors. This is their second year. We're very glad to have them. We really do believe in their products, and their service is hands down one of the best we've seen. So as you know, they've been around in the industry for a long time. It's family owned, and they offer a wide variety of products. Their catalog is very full, but they have launched several new products in the past year or two, which is very exciting for a company that's been around for a long time to keep innovating. So I will turn it over to Chris, and then we will launch into our presentation with Dr. Markinson.
Thank you, Ann, and thank you, Sarah, for having us here, and welcome everybody who's joining us online, and a special welcome to Dr. Bryan Markinson, a very well-respected industry leader and the Chief of Podiatry at the Icahn School of Medicine, Mount Sinai Hospital. Bryan, thanks for joining us tonight.
Thank you for having us. Good evening, everyone, and welcome to Breaking the Fungal Recurrence Cycle, the Importance of Disinfecting Footwear. My name is Dr. Bryan C. Markinson, and I'm from the Icahn School of Medicine at Mount Sinai in New York City. My disclosures for this presentation are that this is a non-CME talk, and it is sponsored in whole by Pedifix Medical Foot Care. The information and opinions herein are in no way endorsed or supported by the Icahn School of Medicine at Mount Sinai. So the subject of shoe disinfection comes up predominantly when podiatrists or dermatologists are discussing fungal infections of the feet. So as we get into the body of the talk, I'm going to review some of the basic science of fungal infections of the foot, and then we will get into the science on disinfection. So the pathogenic fungi are classified as superficial or deep. The organisms that cause Tinea Pedis or onychomycosis are superficial fungal organisms. There are three genera of superficial fungi, and they include the microsporon, which is rare on feet, the epidermophyton, and trichophyton. The trichophyton genera is the most common cause of Tinea Pedis and onychomycosis. Dermatophytes harbor on the skin by settling on the skin and emitting an enzyme called keratinase, which breaks down the structural integrity of nails, hair, and stratum corneum. Tinea Pedis, when viewed globally, is a serious medical concern. It is the most common fungal infection worldwide today, and it's also noted to be spreading fairly rapidly. It affects approximately 70% of the United States population. When not treated properly, it may be a risk factor for the development of onychomycosis, bacterial cellulitis, and flares of eczema and asthma. This slide is an important slide because when we speak of the cycle of fungal recurrence and chronicity, we are talking about the facts that dermatophytes can survive off of the human body as spores. They are, in fact, ubiquitous. It is almost impossible to avoid contact with dermatophyte organisms in life. There is a genetic predisposition to chronic infection and recurrence of Tinea Pedis. Patients with chronic infections may and usually do shed spores throughout their home. Patients may reinfect themselves and other family members who may also be genetically predisposed. Now, when I say dermatophytes are ubiquitous, virtually any place that you can go to can be teeming, in fact, with dermatophytes. So first source is animals, other people, clothing, as you see here, footwear and socks, damp surfaces, pool, gyms, anywhere there's a tendency for moisture on the ground, in soil, for those who are active in gardening and landscaping. Certain types of community prayer involve barefoot prayer with multiple people in the same area. Gyms, wrestling mats, and exercise mats are also usually teeming with organism. And again, speaking genetics, there's a susceptibility factor that is involved. So all of these areas are places of possible contamination with the dermatophyte organisms that cause initial infection. Now, there are two types of spread. One is called extension, which means it's going to a contiguous site. And in that example, we would talk about Tinea Pedis going to cause onychomycosis, as well as Tinea manum, because your hands are readily on your feet. So these are direct extension to contiguous sites. The second way that people can get a dermatophyte infection is by transfer of the primary focus on the foot to a second body site, causing either tinea cruris or tinea corporis. And the typical way that these are spread is with towels after bathing. So we become aware then that Tinea Pedis, which is generally referred to as a very benign common infection, can and does lead to more complicated issues on other sides of the body. Based on this mechanism of transfer and extension, the concept of shoe sanitization potentially has far-reaching implications in inhibiting body-wide infections. Now, there is a very strong association. Some people, including me, feel that it's virtually a 100% association between chronic dry scaly tinea pedis and onychomycosis. So, in fact, we know that without aggressive treatment of the skin, it becomes very difficult to get any success on systemic treatment of the nails. The course of disease starts out as recurrent acute infections leading to chronic infection. When the toenails become involved, cure is very difficult, as you already know. T. mentogrophites causes most vesicular acute infections, which respond readily to treatment and do not really become implicated much in chronicity. T. rubrum, however, is responsible for most chronic scaly infections and is the culprit most of the time in onychomycosis, and it is much more difficult to cure. Now, Moschella, Pillsbury, and Hurley, in their text many years ago, categorized types of tinea pedis as dry squamous inflammation, vesicular and bullous lesions, and intertriginous inflammation. So we're just going to add to that the development of onychomycosis, which again occurs mostly as a result of the dry squamous inflammatory type, but possibly, of course, can be derived from these other types of tinea if they become repetitive and chronic. So these are 3 photos showing the acute vesicular, chronic dry scaly, and interdigital types of Tinea pedis. We know that the acute vesicular type is most commonly occurring in the long arch area, and it is recurrent in web spaces and toes. Blistering is noted clinically with accompanying severe itching, and we know from experience that the areas that itch the most are the ones with the fresh bullous appearance. However, the good thing is that this infection is very easily treated with commonly available topical antifungals. The interdigital type of Tinea pedis is most common in the 3rd and 4th toe webs, but may involve all. Yeast, bacteria, psoriasis, as well as dermatophytes may be involved. When bacteria is present, it is very difficult to isolate dermatophytes. And erythrasma, which is a interdigital corynebacteria infection, is also a concern. So when we have a situation of interdigital tinea or interdigital maceration and erosion, the diagnosis can be quite difficult. Remember that the humidity in a closed toe web is high and creates a perfect environment for thriving of multiple organisms. The chronic dry scaly type, or Moccasin Tinea pedis, has a high incidence in men over 20. It's very often mistaken or mistreated for dry skin. Toenail involvement, again, is eventually almost a certainty with very high association, and it is a common focus for tinea elsewhere on the body. I also want to remind the audience, like we said a few slides before, that a focus of chronic tinea on the feet can very often exacerbate allergic phenomena in people who are susceptible to breathing difficulties and respiratory allergies. In addition, it could be a common occurrence where flares of eczema in susceptible people can occur due to the presence of a focal fungal infection. The presentation would not be complete without a list of conditions that may resemble Tinea pedis. And here you have things like atopic dermatitis, contact dermatitis, erythrasma, which we mentioned before, lichen planus, psoriasis, even cutaneous lymphoma has been known to mimic Tinea pedis at times. So in any time of area of recalcitrance, it is very important to consider the possibility of one of these alternate diagnoses. Now, treating onychomycosis and Tinea pedis should not be just confined to the nail. Dermatophytes are known to colonize and survive for a long duration in footwear worn by patients with onychomycosis and Tinea pedis. Fungi may use sweat and skin cells trapped in footwear as a source of nutrients to create and maintain fungal reservoirs. Contaminated socks and shoes can and do act as a source of reinfection when worn by patients after achieving cure with antifungal therapy. So with these things proven in scientific experiments, it becomes virtually a certainty that failure to address this fungal reservoir in shoes can significantly hamper therapy or delay or even help avoid success. laboratory diagnosis prior to initiating treatment must be emphasized because this enables the rational choice of the antifungal agent that's going to be used. So empirical treatment, based on the fact that these infections can become out of control, is frowned upon. And it is always better to treat with laboratory confirmation of diagnosis. In the case of resistant infections, which we'll discuss in more detail a little bit later, antifungal susceptibility testing is recommended. Now, you hear a lot now about emerging resistance of dermatophytes, and we will discuss this briefly at the end of the presentation. Effective management of onychomycosis includes disinfection of fungal reservoirs in shoes and socks, including post-treatment prophylaxis. Therefore, ultraviolet sanitizers have been developed to irradiate the inner soles of shoes and reduce fungal burden, as fungi absorb UV light with germicidal effects. Now, the typical in-shoe wavelength of UV cidal light that is used is 254 nanometers, and irradiation with this wavelength is one of the most common techniques and elicits a highly germicidal effect. In addition to fungi, it's effective on bacteria and virus particles. The mechanism is mainly related to the absorption of UV light by nucleic acid components, causing damage to the DNA of the organism. Extension of T. rubrum hyphae was strongly inhibited by 254 nanometer UVC irradiation. Now, this is a graphic of the effect of 254 nanometer UVC light. On the left side of the frame, we see the hyphae on culture before plate irradiation. And in the top frame, where through no irradiation, you can see the hyphae multiply rapidly and take over the entire surface of the plate. And where the radiation was used on the bottom three frames, you see that virtually no hyphae survive. And of course, the ability to infect depends on the numbers of organisms that can survive. So this illustration dramatically shows the contrast between an untreated organism and a treated one with the UV cidal light. Now, antifungal resistance comes in two forms. One is clinical resistance, and I believe that this is what we are seeing currently, where most people are saying that the dermatophytes have developed the ability to be resistant to terbinafine, for instance. I think the vast majority of those cases are what we call clinical resistance, which is a hodgepodge of variables, including incorrect diagnosis, delay in initiation of therapy, suboptimal dose of the drug, insufficient duration of treatment, poor drug penetration into the nail plate, drug-drug interactions, patient noncompliance to the treatment regimen, and relapse or reinfection. So clinical resistance is the type of resistance that's related to host or drug-related factors. In microbiological resistance or true organism-related factors, we have both innate primary resistance, which is a innate structural or functional characteristic of the fungus that contributes to resistance, And then we have the acquired secondary type, which is due to overexpression of the drug target, an altered drug target, upregulation of efflux pumps in the organism, decreased prodrug metabolism, drug sequestration in biofilms or the development of biofilm that increases resistance, and mannan expression on fungal cell wall to evade the host immune response. So in conclusion, dermatophyte infections are an expanding global problem. In certain high-risk profile individuals, such as diabetics, those with PVD, in the immunosuppressed, these infections may lead to more serious complications and other infections. Exposure is virtually impossible to eliminate. Host susceptibility is largely genetic in chronic cases, and footwear is a major reservoir of organisms. So therefore, shoe sanitization makes total sense as part of a multi-pronged approach to preventing, managing, and limiting recurrence of dermatophyte infections. So this concludes the presentation. I thank you for your kind attention, and we will be able to take any questions at this time. Again, thank you very much for viewing this presentation tonight.
Okay, welcome back. Thank you to everyone who sent up a little heart or any kind of emoji during the presentation. It let me know that you were paying attention, and I appreciate that. So if you have any questions, just as a reminder, go ahead and type them into the Q&A or the chat, and we're going to get those answered. We've got a couple in there right now. So I'm just going to fire off the first one. Dr. Markinson, are you ready?
I'm ready.
Okay. Oh geez, there's a lot of words. How do you address fungal biofilm in the treatment of onychomycosis, and what is your treatment of choice regarding onychomycosis?
So any discussion about biofilm and its effect on difficulty to treat the infection is somewhat controversial. The real issue on biofilm, in my opinion, is the adjunctive measures that we use to treat and kill the organism. And that includes applying topical antifungals to the skin to eliminate that reservoir. It includes good hygiene practices. It is amazing how many people don't shower every day. Okay. So we could also talk about shoe sanitization now, which is not commonly used, but as part of a full scope effort to treat these infections, it's got to be done. If you are advising people to wipe out their shoes with Lysol, it may be better and more convenient to get into the UV light treatment. My treatment of choice regarding onychomycosis was developed in the mid-90s and has never changed, and there's nothing in the literature that supports anything better than oral terbinafine for the treatment of onychomycosis. But I do use adjunctive measures like I described, and the antifungal cream on the skin is a measure that I use for the life of the patient. So the literature, unfortunately, does talk of about a 70% recurrence within 3 years after successful treatment. And I believe the vast majority of those is due to lack of persistent avoidance and adjunctive measures on the part of the patients.
Okay, our next question. I apologize, I'm a little raspy tonight, as if you've joined us, you're probably used to this. This is how it's just isn't that my voice now. Are there prospective studies demonstrating a reduction in Tinea Pedis relapse with the use of UV shoe sanitizers?
So the majority of the literature on UV sanitization of or elimination of or inhibition of fungi is on inanimate objects, vectors and fomites of infection. So the results are only extrapolated that if we remove or inhibit the source of infection, that it should have a positive impact on Tinea pedis. But it's impossible to really study that because we're generally dealing with patients who already have established infections on a chronic basis. So it's very hard to produce a study that's going to monitor and show that these things are working, because the shoe sanitization variable is one small, tiny variable. If the patient is using a shoe sanitizer and they're going to kickboxing class 3 nights a week and working in a sweaty gym and taking a shower in that place, it's just impossible to really evaluate it as a isolated variable.
All right. How often does a patient have to use the shoe sanitizer?
So most of the studies say that this should be used on a daily basis, that as soon as you take the shoes off, you should use the shoe sanitizer. There are some that call for 15 minutes, some call for 45 minutes. I'll leave it to Christopher Case to discuss that about the duration of treatment. But it should be done every day, certainly, as soon as you take off the shoes that you've been wearing for that day.
Chris, what do you have to add as far as your
Yeah,
experience?
that's especially important, and especially as Dr. Markinson mentioned, a lot of patients are not particularly hygienic who are suffering some of these conditions. So sanitizing their footwear becomes more important if they're wearing the same shoes every day without changing them and allowing them to dry and disinfect somewhat naturally. If they're wearing the same socks over again, if they're not bathing on a regular basis, daily use for anyone fighting an active infection of skin and nails, daily use is highly recommended. For shoes that are worn less often, seasonally, they can be disinfected less often. But if somebody's everyday footwear is not, it's a source of reinfection in most people's minds, and it needs to be cleaned every day.
Do you have any sock disinfection recommendations?
We have had many patients and customers, doctors as well, that use these in socks to disinfect the actual material and the fabrics of hosiery, and it does work, and it is effective, and it's easy enough to do.
So in the literature about sock disinfection or laundry in general, unfortunately, flies in the face of environmental concerns, because it requires very hot water temperatures to kill the organisms. And most people are using cold washers now for environmental concerns. But if you're going to use it in the laundry, you have to put it on a hot setting. And there are studies that show that organisms congregate in the toe area and heel areas of both shoes and socks. My concern, Chris, if they use a sanitizer in the sock, do we still have the same mechanism to shield us from the looking at it or leaking out of the
Yes,
garment?
The sanitizing devices can be used to sanitize anything, including household objects, babies' toys and phones and UV masks, COVID masks, et cetera, as long as they're placed inside the UV-proof safety bags, so no one's looking at the light. And even if it's done without the safety bags, as long as no one is looking at the light, it is quite safe. There's no radiation exposed other than the light radiation, and that's what you don't want to look at. It won't give you a suntan.
Okay, good.
All
That's
right,
I was gonna buy it now if I'm not getting tan.
that's too bad. What do you use after oral Lamisil if a patient does not have a 100% cure rate for onychomycosis? Diflucan
So-
pulse dosing?
So you have to define cure. Are we talking clinical or mycologic? So very rarely Does a patient resolve to the point of those clear 10 toenails that they were born with? Some of these nail dystrophies that we see, and the term nail dystrophy means any alteration in color, shape, or brittleness or anything like that. Some people, if you have a marathon runner, you may get a good clearing of the fungus, but you still may have a thickened nail just based on that type of situation. So I would say that if you really think that there's still some organism growing in the nail, you should just continue the Lamisil. There's nothing magical about 90 days or pulse dosing over a year. So the pulse dosing regimen, which I use 90% of the time, calls for 4 pulses in a year. But I have many patients who have continued it every 3 months for 3 and 4 years now, and that's what keeps them in clinically as good condition as they can. But you really have to evaluate and make sure that the patient is doing all the adjunctive measures that you've asked them to do. Otherwise, you're just chasing the organism without eradicating it adequately.
Okay. Let's see. So, when do you recommend toenail removal? I'm sorry, getting tongue-tied. When do you recommend toenail removal after failed antifungal regimen?
Never. I never heard of that as a treatment, and I don't know what I'd be treating by removing the toenail.
All right, so here's a follow-up about the pulse dosing. Can you explain your pulse dosing on Lamisil? And apologies if you already said that.
So it's not my pulse dosing. This was a major study done by Nardo Zayas and Rebel in Florida in 2004, I believe, published in the Archives of Dermatology. What happened was, in the late 1990s, the scare about Lamisil amongst clinicians and the public based on hepatotoxicity caused many people to get started on the 90-day dosing, and then they would go to a Christmas dinner with family, and Uncle Joe would say, "You can't take that stuff. It's going to kill your liver." And many people would stop after, let's say, 1 month of taking the tablets because they would be afraid of developing liver damage. Lo and behold, we noticed that many of those people cleared with only 30 days of dosing, which is a third of the 90-day recommendation of the company and of the FDA approval. So Dr. Zayas and Rebel did a beautiful study that asked the question, how little can we give and get the same effect? So they took 3 or 4 different arms of study, and they put some people on 1 pill a day for a week, 1 pill a day every second week, 1 pill a day every third week, 1 pill a day every fourth week. Okay, excuse me. Those are months, not weeks. So the people who took 1 pill a day for a week every month had the same effect as 90-day dosing. The people who did it one a week, 1 a day for a week every 2 months had like a 98% as effective as 90-day dosing. And the people who did 1 pill a day for a week every 3 months were like 96 or 94% as effective as 90-day dosing. When it went to 4 months, the results went down to 43%. So the answer to the question was 1 pill a day a week every 3 months. That means a total dose yearly of 28 tablets, which is a 70% reduction in total dose, is the same effect as 90-day dosing. Of course, the company that made Lamisil was not interested in doing a study to prove that. So that is an off-label use of Lamisil, which is very popular today. But I have to caution the audience. I've lectured this and spoke about this exactly like I just did hundreds of times, and everybody walks away with a different interpretation of what I said. The treatment is 1 pill daily for 7 days, every 3 months. Not every month, not every week, not every third week, 1 a day per week, 1 a day for a week, every 3 months.
Okay. All right. This next question. I was told Pedifix also purchased SteriShoe. What are the key differences between SteriShoe and ShoeZap, and will SteriShoe be available soon?
Great question with someone with inside knowledge. We haven't even announced that publicly yet, and it's already a scoop here at podiatrymeetings.com. Yes, we recently
You heard it here
acquired
first, folks.
important assets of SteriShoe, namely their patents and product designs and tooling. And we're right now considering our options. In short, they have 2 models. The low-end essential product is essentially comparable to our ShoeZap. It uses the same 3-watt UVC bulb that was proven in their studies that were published in the APMA journal several years ago. They have a higher-end model with a fan and scent pouches and some stronger bulbs, 2 of them in each unit as opposed to just 1, which probably does a faster job and more thorough job of sanitizing and drying footwear, which is also helpful. We're not sure if we're going to reintroduce 1 or both models just now. We're just kind of digesting the company and deciding how we're going to move forward. It is very likely that we'll come out with a higher end model, and that the ShoeZap, since it's very comparable to the essential model, the original SteriShoe design, will probably remain as the somewhat less costly product.
Okay. Do you base your diagnosis of Tinea Pedis on clinical assessment before starting the patient on oral antifungals, or do you always take a sample to be tested prior to starting a patient on an oral antifungal?
So I have very strong opinions on this. There are way too many of my colleagues who treat empirically because they think when they look at a fungus toenail, they know it's fungus. They're probably right 85% of the time. However, the 15% where they're wrong involves the prescription of agents that can cost $5,000 to $6,000 a year. And to me, that is an abomination to allow that amount of patients being treated empirically that might be the wrong drug. So I never initiate any FDA-approved therapy, whether it be topical or oral, without laboratory confirmation of what's growing in that nail. And I would caution anyone to do otherwise. I was involved a few years ago in a malpractice case, which had nothing to do with not ordering a culture. What it had to do was it was with a very idiosyncratic reaction to terbinafine, where the patient died waiting for a liver transplant. But the key issue in the case that the plaintiff's attorney brought up was that no laboratory confirmation was done that he even had an infection that would be treated by that drug. And because of that, this is a federal government case. Because of that, the federal government said the exposure is too great and we had to settle. They had to settle that case, even though the same thing would have happened to the patient if they got a culture. You understand? Because it wasn't about the culture. It was about the reaction to the drug, which is unpredictable no matter what. So you should never initiate systemic therapy or topical FDA-approved therapy without a laboratory confirmation.
All right. Let's see. Oh, do copper or silver fibers in socks inhibit Tinea Pedis?
There was literature that supports, again, that they inhibit growth of fungal organisms, but it's hard to translate that into having a direct effect on Tinea Pedis. So it just makes sense, okay? Just think about it. If you spray toilet bowl cleaner to disinfect your toilet bowl, it just makes sense that sanitizing your footwear or wearing copper sock materials shown to in a petri dish to inhibit organism would make sense that it would probably help in the treatment of Tinea pedis.
Important distinction there between inhibiting the growth of something and killing the microorganisms that cause these infections is what I'd add as a cautionary note.
Absolutely.
So Chris, here's a question about the manufacturer's recommendation. So what are the manufacturer's recommendations for the frequency and duration of the use of the shoe sanitizer? We touched on this, but for the people in the back.
It's daily and from all standpoints, because fungus can accumulate in footwear overnight or in a day or two. If you're perspiring a pint or a pint and a half a day, as most people typically do, and especially again, if patients are not compliant with bathing or changing their socks and shoes every day, it is a reservoir of microorganisms that are just waiting for the chance to reattack the feet and nails. So daily use is my highest recommendation. And that comes from all the manufacturers. And UV light, same thing. You run in a hospital room to disinfect the air. They don't just do it once. They do it after every patient or after every procedure. They do it multiple times a day because that's what's required to kill the microorganisms, because they will breed uncontrollably in the warm, dark, damp environment.
All right, I got a little distracted for a second, so I don't know where we are on the list. So I'm just going to grab one, Ann, and you're just going to have to figure it out. All right. How often do you take blood tests?
Every patient before the initiation of therapy with oral medication gets a blood test. Not that it's required or recommended, but no matter how good a history you take, you really never know if the patient has any pre-existing liver disease. So I always get bloods before. I do not get bloods during or after. That is definitely not recommended, and that was an initial recommendation that the FDA took away. So just prior, then that's it.
All right, so a follow-up to an earlier question. Do you always take a skin scraping for a sample prior to starting any oral antifungal? Always.
Well, I only use oral antifungals for onychomycosis. So the answer to that is yes, there's always a specimen of the nail. But for Tinea pedis, I'm less concerned about a misdiagnosis because I'm going to be prescribing a generic topical antifungal, which if in 10 days doesn't get me relief, then I'm pretty sure that I'm on the wrong track. But I will tell the audience that for chronic scaly erythematous rashes, a study has proven that 2/3 of the time, these are dermatitis and not fungal. So they did a whole bunch of fungal scrapings for people who just presented with erythematous and scaly dermatitis. And 2/3 of the time, those were negative for fungus. So if you're treating empirically, you're smarter to start with a topical steroid first. There's some concern that if you put a topical steroid on a fungus organism, that it will get really out of control. Some people have experienced this. I have never experienced it, but it is a possibility. But I do not take routine skin scrapings for a beginning treatment of Tinea pedis, unless down the road I have failure of both antifungal and a steroid, and then after a washout period of about 3 weeks, I'll do actually a skin biopsy.
Okay. To clarify, the Lamisil pulse, is it 1 pill a day every, I'm sorry, I'm going to start that one over. To clarify, which I'm not being very clear, the Lamisil pulse, it's 1 pill a day every week for 4 months.
Right. So one thing is for certain, no matter how many times I repeat it, it's going to be heard differently by different people. So it's 1 pill daily for 7 days, and you repeat that every 3 months. So January 1st, April 1st, July 1st and October 1st, they start 1 week's worth of the pill. There is a 2-month and 3-week holiday between pulses. Adjunctively, everybody gets topical antifungal creams for the skin to be applied daily. And that's how we do it. I give the patient 14 pills at the beginning to make sure they come back in between the second and third pulse, and then I give them fresh medicine for the next 2 pulses. And again, I'll just repeat, I have many patients who feel that it works so well that they stay on it, and every 3 months they take a week's worth of Lamisil.
All right, thank you for clarifying. Do any topical agents combined with sanitizer shoes effective? I think this question is, are there any topical agents that when combined with sanitizing shoes are more effective?
Well, these should not be a question of combination. You should be using topical agents on the skin for treatment of the infection. So it's not a question of combination. The sanitizer is an adjunctive treatment for the problem.
So it's not like wearing a teeth whitener and a tanning bed. It doesn't make it work better.
Right.
How
Okay.
do you
Right, it's-
order a fungal susceptibility test?
So fungal susceptibility test is a big issue these days with the discussion about dermatophyte resistance to terbinafine, which is very controversial. Now, you have to all realize that there's always been resistant organisms to terbinafine from day one, which explains why there are failure rates from the use of terbinafine from day one. The only explanation of that had been that some dermatophytes are just not going to be killed by terbinafine, but nobody made a big deal out of it. A few years ago, some laboratories were reporting that in the laboratory alone, there were dermatophytes, surging amounts of dermatophytes that were not being killed by terbinafine. So they started going into the question about the genetics of the organism and PCR, and lo and behold, we now have a whole industry of ordering, terbinafine resistant tests. And I believe that it's way overdone. The current literature, the one cited in my presentation from Drs. Gupta and Somerville, 2 of the most globally decorated mycologists in the universe, say specifically that susceptibility issues should be only considered in infections that are showing themselves to be recalcitrant, and it should not be a routine procedure. This may change in the future, I don't know, but I think the whole question is that it's been overdone. You should wait to see if the infection is showing itself to be resistant with proper laboratory confirmation prior to starting treatment, and then you should start to think about the possibility of terbinafine resistance.
All right, well, congratulations. You made it through all 20 plus questions, and we didn't stump you once.
We do have another one that popped in really quick, if we have time.
Go ahead.
Please comment on the off-label use of diflucan.
Diflucan.
Okay, that's
Okay.
one. That's a new one for me. Pharynchomycosis. I've been around for a
So-
while. I don't know that.
Okay, so that's fluconazole, and fluconazole was poised for FDA approval in onychomycosis many years ago, and the company that made it had a big meeting a day or 2 before the FDA announcement was pending, and they were ready to start a huge campaign, but the FDA nixed it. The FDA did not approve it for onychomycosis, so therefore it is off-label. But the utility of diflucan for me is some patients can't get the pulse dosing in their head. They just can't do it. They forget. So the beauty of diflucan is that it's one pill a week till the infection clears. I use diflucan as first-line treatment when my laboratory tests come back with candida infection of the nail. Fluconazole is a preferred organism over terbinafine for yeast infections. And that's one of the real good reasons that you need to do laboratory confirmation.
So we've had a couple comments come in, Dr. Markinson, related to subjects that are off topic. What is a good email address that I can share of yours for people to contact you with questions following up on this? Or like one person is asking about a dermatology fellowship. So what's a good contact?
You have to be a dermatologist to do a dermatology fellowship. But I'm happy to talk to anybody. My email is Bryan with a Y .Markinson, MARKINSON at Mount Sinai, MOUNTSINAI.org.
All right. And I'm going to drop that in the chat for anyone.
And I think we'll just do this one last question before we wrap up then tonight while Anne's typing the very long mail. So what exactly do you order? Name of test for nails. Some labs suggest PCR and other tests, which cost lots of money.
I order a PAS stain and a fungal culture. The key, I get 95% confirmation with those two tests. The key is the correct specimen. If you're taking distal nail clippings and sending it, you will not get consistent results. You have to take deep subungual samples of the subungual skin and send that material. That's where the organisms are most numerous and most viable. So specimen collection is key in getting the right results. In the dermatology world, where almost all of them have microscopes, they do a KOH prep in their office and they're good to go. But that is not a podiatry reality. So I recommend fungal culture and PAS stain. That's it.
All right. Here's one for you, Chris. What's the best way for doctors to contact you or Pedifix with questions related to the product or ordering anything like that?
Yes, well, if there's any questions about the device, similar to Dr. Markinson, my email address is my name, christopher.case@pedifix.com. I welcome any questions or comments. And in terms of ordering, we did arrange for a special deal for webinar attendees tonight. I really want to encourage people to experiment with the Shoes app device. So we've given a buy one, get one free offer to all webinar attendees tonight. There's a special code that if we do everything right, will work on our website, or you can call and say you're at the webinar. But I really want to encourage people to try to use it. Either they can use it at home or more importantly, they use one in their office and treat patients' shoes while you treat their feet. When they come in for a visit for fungal care, nail care, whatever it might be, and you remove their shoes, you immediately zap them right there during the appointment, and you hand them back a clean pair of, microscopically clean pair of shoes when they're leaving the office. And a lot of patients will understand the benefits of that and want to purchase one of their own. And so that's why we're offering you two. Is one, you can use it at home and one in the office in your treatment room. The other way is to keep the other one, the second one, for a patient who might want to purchase one from you. And patients can buy it directly from us. We're debating whether to put Shoes app back on Amazon.com. We've had it on and off over time, or they can order it directly off our website as well. So for questions or comments, christopher.case@pedifix.com. For orders for physicians or their patients, you can call into our offices or order online with the code PMC228. PMC as in podiatrymeetings.com, 228 being today's date. PMC228 gets you a 50% discount, buy one, get one free deal. And I encourage you.
Awesome.
Sauce.
I
Love
just
that.
dropped all of those details into the chat. So make sure you copy that, save it for later. Yeah. Sarah, what do you got?
I don't have anything majorly mind-blowing. Dr. Markinson and Chris blew everyone's minds enough, so that's good news. Did you, go ahead, Markinson.
Just
looked like
one
we're gonna say
question here
something.
about diflucan dosing. It's 150 to 300 milligrams per week.
Awesome. And I love this crew. Chris and Dr. Markinson are two of the best in terms of just making themselves available and answering these questions and seriously listening to you and being passionate about these types of conditions. I've seen Dr. Markinson lecture several times, and just the energy behind it is always fantastic. And I'm just very, very excited that you guys took the time to be here with us tonight. It really elevates our Practice Partner Academy. So just thank you so much for being here. And I think you can see by the amount of attendance that we had this evening that this is a topic that is very important to the industry. So I just want to say thank you again. For everybody who's still on, just so you know, the next couple of weeks, we have more exciting webinars for you. In the next couple of weeks, we will have our monthly marketing with Randy Rossler of Podiatry Content Connection. And then we will also have what causes a flat foot deformity and does it always need treatment with Dr. Doug Ritchie. So we will be promoting those in the next couple of days and weeks. So keep your eyes peeled. And I just hope everyone has a wonderful night.
Yeah.
And that you are all tanner than me because
And,
I realize I'm a vampire.
as a reminder, if you want to rewatch this because you just love it so much, or if you missed an important part, it will be available on our Practice Partner Academy archives page before the end of the week. So you can catch the replay on that. Don't forget to grab their contact information from the chat so you can ask any follow-up questions. And thank you, Chris. Thank you, Dr. Markinson, for being with us. We know your time is valuable, but we appreciate you spending the time with us.
Shout
Had
out
a
to
blast. Thank you very much.
Thank
And
you.
thank you, Sarah. Thank you, Dr. Markinson. Really
Absolutely.
appreciate you being here. Great talk.
Okay, now, good night.
Good night, everyone.
And everybody.
Thank
Good
you
night,
for attending.
everyone.
See you soon.
See you at the next conference.